Hello everyone, my name is Holly Damude and I'm with the Wound Care Education Institute, powered by Relias, and I would like to welcome you all to today's webinar, 5 Key Steps for an Accurate Stoma Assessment. Our program today is made possible by a grant from Shield Healthcare. This event has been created to provide an opportunity for education related to clinical topics that affect the wound care market today. WCEI is now a Relias company and continues to have one goal in mind: to improve the management of wounds and ostomy for patients across the nation. We currently support over 43,000 alumni through resources, webinars, seminars, our conference, as well as certification courses in wound care, diabetic wound care, ostomy, and nutrition wound care. WCEI will be hosting our annual Wild on Wounds National Conference virtually this year. During the conference week in September, there is an opportunity for those who wish to become certified to attend live certification courses in Las Vegas and receive the virtual WOW conference as a bonus. Details can be found at woundseminar.com. Registration is open now. The accrediting body for this program is on the screen now. And now I would like to introduce today's speaker. Joy Hooper is a registered nurse with over 20 years of wound and ostomy care experience and has practiced in a variety of hospital and home care settings. She is a successful nurse entrepreneur as owner of Medical Craft LLC and Aprons by Joy Anatomical Aprons. She is board certified by the WOCN as a CWOCN and by the NAWCO as a WCC and OMS. Her informal and down-to-earth teaching methods enable students to learn easily in a relaxed and enjoyable environment. Joy is the lead instructor of our ostomy courses and also serves on the advisory committee for Safe and Simple. Hello, Joy, and welcome.
Hi, Holly. Thank you very much. Hello, everybody. I hope you're ready for an exciting hour to talk about ostomies. And we are going to specifically get into the assessment of an ostomy. Now, you know, I'm saying the word ostomy. Ostomy and stoma actually get interchanged a lot when they shouldn't be. The ostomy is the surgical creation. That could be a colostomy. It can be an ileostomy. It can be a urostomy, but it's a surgical opening, this creation into the body. The stoma, well, that's the actual little piece of, in our case, intestine that's out and up on the surface of the abdomen that the person is going to be looking at. And this, of course, is where the effluent, which is our next word of our terminology, is going to come out. Now, what is the effluent? Well, that's anything that's coming out of the stoma. It can be urine, it can be feces, it can be gas, and it can be mucus as well. As we talk about these different surgeries, the term diversion is also used. You know, a urinary diversion, a fecal diversion. And as we talk about diversions, the ones that I'm focusing on today, those are incontinent diversions. Colostomy, ileostomy, urostomy. Those are the common ones. They're incontinent ostomies, so that means the person is going to need to wear a pouch. But there are continent procedures that are done as well for both fecal and urinary. A skin barrier. Well, when I'm talking about the skin barrier, I am talking about the wafer or the face plate. You know, these go by different terms. We're using barrier now. And the reason we're using barrier is when you look in your DME catalogs, the terms are varied. And so we're trying to get all on one term. So we're saying this is the barrier. Now that's different from a skin barrier, but this is your ostomy barrier. When we're talking about the appliance, we are talking about the whole thing. So this is the barrier, the pouch, or it could be a one-piece system. So this is a one-piece system where your barrier and your pouch are connected together, and this, of course, would be two-piece. So as we're doing our stoma assessment, what we're focusing on is getting the information from the stoma and the peristomal skin. And your peristomal skin is, of course, that skin that is all around the stoma. When you're doing your assessment, The frequency that you're going to do your assessment with is going to be based on, when did this person have surgery? Is this a new stoma? Am I in acute care? Or am I in home care or long-term care? And this person comes to me with an already matured stoma. Know that if it's post-operative where you're working, the stoma needs to be assessed every 4 hours for that first 24 hours. If this person is in your long-term care facility, or if this is somebody in your home health, one of your patients, you're going to be doing a stoma assessment on each visit and making sure that you're documenting on your patient at least every week. Now, if we could say, what is the ideal stoma? What is the perfect stoma? Well, we would say it's going to be one that's round. Why is round perfect? It's just convenient. So that's why it's ideal. It's convenient because you could get a pre-cut opening in the skin barrier. It's convenient because the measuring guides, the majority of them are circular. Now we're getting several that are also oval, but it used to be your measuring guides were simply just circles. We definitely want it red. That's letting us know it's got good blood flow. Now, I will get into some pink stomas in a little bit that can be okay, but typically we say red. And it should be moist with its own natural lubricant because it's mucosal tissue. We want it budded. Do you see how this has a protrusion right there? You know what the protrusion is for? The protrusion is so when there's a pouch on it, this stoma protrudes, and that is allowing the urine or the feces to actually just fall down into the pouch, and that's what you would really like. The protrusion, I explain this to my patients, and sometimes it's really important to explain this. Like if this is a woman and she wakes up and she has a moderately protruding stoma on her abdomen, she can really be upset with the way that it looks. So you got to sell it to her. You got to make her understand this is what you want. You want a stoma that protrudes from your body, like your faucet protrudes from your house. Think about it. Out in the front of your house, you got a faucet that protrudes and shoots the water, projects the water out away from the house. It's not like you're walking up to the front of your house and pulling a cork out of your wall and the water just runs straight down the front of the wall. If that happened, it would undermine the house. Well, we like the stoma budded, so it projects, it protrudes, and allows the stool or the feces to fall down into the pouch, not oozing up underneath the skin barrier. We love it when we've got 2 to 3 inches of flat surface around the stoma. We don't always have it, but we love it when we do. We like it when the lumen or the opening is right in the center where we can easily see it. Not all wonky to the side, but hey, we see that too, don't we? We want this stoma in a place where the patient can easily see it and easily reach it. It's usually going to be in the lower quadrant of the body, and that's going to allow the pouch to easily be hid in the person's underclothing. And know that the stoma can be created as a permanent stoma, or it could be temporary. When you're doing your assessment, you want to develop your own routine, and you want to follow your same routine each time. And if you do this, you're going to be a lot less likely to leave things out. Most of us are going to start right with the lumen, right in the middle of the stoma, assessing that, and then the stoma itself, and then around it and on out in the peristomal area. Definitely with your assessment, note the quadrant that the stoma is located in. Also, what else is going to be pertinent about this assessment? Is your stoma right next to the umbilicus? Is it right next to the incision and you got a big open incision and you barely have any room to pouch? Is it right next to the person's the hip? And their hip is, this is that real thin person, and that hip is just being a pouching hazard for you. Think about that. Make sure that you're documenting everything that's pertinent about this person's location of the stoma. And as we've got these pictures of the profiles right there on the lower left side, let's take a look at these profiles right here. We look at the one of the little man that's on the far right end, and he's nicely shaped. Not a lot of adipose tissue on his body. But as we move out to the left, what are we seeing? We are seeing increased adiposity. Doesn't that sound good? Increased adiposity. Let that one just kind of mingle around in your head a little bit, because when I heard that, and I heard it at a conference a couple of months ago, I thought, that's the term that I want to use. Joy Hooper's got increased adiposity, not more body fat. No, increased adiposity. Yeah, give me a double scoop of that. It just sounds nice. So in any event, as we move to the left, we see increased adipose tissue on the person's body. Is this going to make a difference? Yes, it's going to make a big difference. We'll come back and talk about that in a few minutes. Let's talk about the different types of diversions. Yep, you can tell I got my apron on, so y'all know what's coming next. Oh, let me lead you through the bowel. Now, I'm going to explain some different types of ostomies. First, I'm going to show you a colostomy, then an ileostomy, and then a urostomy. Let's begin with the colostomy and with the demonstrations, but before I do, let me run through what the GI tract does. You chew your food and it goes down your esophagus and into your stomach. When that chewed up food is in your stomach, it's held, it's churned, it's slowly released to move into the small intestine. And as it makes its way into the small intestine, the liver, the pancreas, and the gallbladder all add in additional digestive enzymes. And that's because when this chewed up food is traveling around through the small intestine, those digestive enzymes are going to break that food down. You've got some muscular movement of your small intestine that's going to help chomp that food up while those digestive enzymes are melting it down, just emulsifying it, so the walls of your small intestine can absorb those vitamins and nutrients and take those vitamins and nutrients and use them for fuel for your body. Now, after that chewed up food has traveled through the small intestine, it's going to travel into the large intestine. As it makes its way through the large intestine, it's getting thicker and thicker and thicker. And you know why? Well, the small intestine ate for you. The large intestine is drinking for you. Yes, the more large intestine you've got, the more opportunity for absorption you've got. And it's going to be absorbing the liquid from the liquids that you drink and the liquids out of the foods that you're eating. And then finally, that chewed up food is going to exit your body as feces right out of your anus. Let's get into the diversions. First one I'm going to show you is a colostomy. That's going to happen in the colon, colostomy. Okay, so the surgeon separates the intestine. I've separated it right here. Now, if this little segment is going to be left intact, if this was a temporary diversion, we would leave it intact so they could be taken down, connected back together. If it's left intact, this section is going to be known as the Hartman's pouch. Hartman's pouch. But sometimes, depending on the type of surgery, it may need to be completely removed and the person's anus removed as well. But for this demonstration, I'm going to leave it right there. All right, now let's get back to this intestine, because we've got food going in here and we've got stool coming out right here. So the surgeon's got to do something. What the surgeon does is, on the front of the abdomen, the surgeon's going to make a small incision. Yep, there's my small incision. Then they're going to take this open piece of intestine. They're going to put it through that small incision. They're going to pull it through, fold it over, and sew it down. And that is going to be the person's stoma right there. All right, so the kind of stool that's going to come out of this is going to be thicker stool because it's moved through a considerable large amount of the colon to have the liquid absorbed. Now, that was a colostomy. I'm going to show you another type of colostomy that has a different kind of stoma. The stoma that I just showed you was an end stoma. The surgeon took the end of the intestine, folded it over, and sutured it down to the skin. But there may be a reason that the surgeon needs to bring both ends out. Now, why would they need to do that? Well, I don't know. Maybe the person was really fragile. They needed to bring both ends out. Maybe it was a lot of trauma in the abdomen, but for whatever reason, the surgeon needs to bring both ends out. Well, they can certainly do that. This is going to be called a double barrel stoma. And just as the name implies, this person is going to have two stomas. We're going to call these the proximal stoma and the mucus fistula. So the proximal stoma, that's the one that's going to be productive. One of the OMS students said that she always remembered this because the proximal poops. I thought that's an easy way to remember it. All right, so the feces is going to come out of the proximal stoma, and what might come out the distal stoma? Mucus. Because you see, you've got this long residual piece of intestine that's in here. So of course, mucus may come out of the top, or it could come out of the bottom. Okay, again, that was a double barrel stoma from a type of colostomy. Now, if the person has to have their entire colon removed, that is going to leave them with their small intestine. Okay, now with the small intestine, I can create that same type of stoma. And if it's coming off of the small intestine, well, it's the ileum section of the small intestine. So this would be known as an ileostomy. And we'll get into the type of effluent that comes out of each one of these in just a second. I just want to make sure that you understand how these procedures are done. Now, what's important about this one for the patient to make sure that they understand is they don't have this connection right here to their colon. With an ileostomy, they don't have their colon drinking for them. It was either removed, or if this is a diversion where we're diverting away from it. But for whatever reason, the person does not have their colon functioning and absorbing those liquids. So this person needs to be taking in extra fluids. Okay, now while I'm standing and have this on, let me go ahead and cover a urostomy. Now, with a urostomy, it goes by another name too, which can kind of be confusing for some people. The other term is called an ileal conduit, but I'm going to explain why really that is a good name for it. Okay, to explain a urostomy, well, the first thing I need to do is pop me some kidneys on here. And I know you're thinking, Joy, that's not where the kidneys go. I know it's not where the kidneys go, but I can't do this demonstration with these kidneys behind my back. And you know, they're supposed to be behind the GI tract. So I just plop them right on the front and roll with it. All right, I've got kidneys, I've got ureters, I've got a bladder, and I've got a urethra. This would be similar to a female urethra. If this was a male urethra, we would want it much, much longer. Okay, now when a person has a condition such as bladder cancer, what usually happens is they're going to need to have their bladder removed. Now, when they remove the bladder, they've got options. They can bring the ureters straight out and create two stomas called ureterostomies. They can also connect one ureter to the other ureter inside the body and just bring one out and make it a ureterostomy. But the reason they don't like to do that is because the ureters make really bad stomas. They're very small to start with, and they tend to stenose, so they don't make good stomas. So what they usually do when they're creating a urostomy is they go to the GI tract and they remove a small piece of the ileum. Now they take this piece of ileum, and actually when they're doing the surgery, they're keeping this connected to the blood supply. So they're just manipulating it around in the abdomen. They're not waving it around like the freak flag I'm doing right now. But they're going to take this little piece of ileum that they freed up, and they're going to close one end of it off. Then what they're going to do is implant these ureters, right, into this little piece of GI tract. Remember, it was from the ileum. And they're going to create a conduit out of this. Now, you know what a conduit is. A conduit is something that carries something from one place to another. Well, this conduit, which is made of the ileum, is going to carry urine out of the body. So creating that same kind of stoma that they did with an ileostomy, the surgeon will bring the end of that conduit out, fold it over, suture it down to the body, and look at there, the ileal conduit. There we go. There we go. Isn't that awesome? You know, a lot of nurses don't realize it, but when somebody has a urostomy that's created, they have not only had surgery on their urinary system, they've had substantial surgery on their GI tract as well. So let's make sure we're listening for those vowel sounds and all. And so many times that gets overlooked because you're focusing on the urinary tract since it's a urostomy. But just know the GI tract was affected as well. Okay, so I just showed those to you, but let's go back over them one time. A descending colostomy, that's going to be located on the lower left quadrant. This stayed, you know, this feces stayed in your body the longest time, so it had more opportunity for absorption. So this is going to be formed output, solid output. You could also have a sigmoid colostomy, a little bit higher up. I said that backwards, a little bit lower down within the colon. And this, of course, is going to be formed in solid output as well. The ileostomy, that would be on the right lower quadrant of the body. This would be completely diverting the colon or diverting from the colon, or maybe the colon was removed. This output is going to be a lot more loose, you know, semi-liquid. Some people have it more paste-like consistency. It's not typically your brown feces color, and it doesn't have that characteristic fecal smell either. Now, I touched on continent diversions in my opening. The continent fecal diversion that I'm showing right here, this is a coke pouch, also called a cock pouch, and it's made of loops of intestine. Usually it's the small intestine that's going to be used. That's what they use to create an internal pouch. It's going to be connected to the small intestine. This internal pouch is going to be the collection receptacle that is going to eliminate the need for a traditional appliance. And the person will simply catheterize it several times a day to empty the feces out of this internal pouch. And at least once during the day, they're going to irrigate it because, you know, the small intestine secretes a lot of mucus. So it's going to, you know, get the mucus out of that internal reservoir as well. A urostomy, I showed you this one. This is usually in the right lower quadrant of the body. And many times this is the stoma right after it's created, it's going to have those stents in it. You know what I'm talking about? Little stents that you're going to have to work around. Yep, they're there. You can have continent urinary diversions as well. Now, the picture on the left, that's showing you your typical conduit. That was the ileal conduit. So that one would actually be an incontinent diversion. Your continent reservoir is over on the right. There you go. The term for this one is the Indiana pouch, is the most common one here in the United States. Now, your continent reservoirs, the one that you're looking at on the screen, actually that continent reservoir, instead of being brought out and having a stoma, that one is actually connected to the person's urethra. And so it's essentially a new bladder for the person called a neobladder. Again, when a person has a stoma created, it can be permanent or it can be temporary. When I'm talking about stoma construction, I touched on this a second ago, an end stoma is using the end of the GI tract. It's folded over and sutured down to the body. It has one opening. And then your loop stoma. Well, the loop stoma is a little bit different. Surgeon's going to pull out a loop of the intestine. Now, they usually use some type of stabilization rod or retaining rod. You're going to slide it through there. It's usually sutured down to the body to allow the stool to exit from this loop, what the surgeon does is make a split in it, and then they fold it open. Now, did you notice when I folded this open, the back wall comes up and creates a septum? Yes, so I have a proximal and a distal opening into my loop stoma. Now, sometimes the stoma looks like this. Sometimes the stoma looks like this. Oh, I'll go ahead and say it. Sometimes it looks like that and you can't even see it. But sometimes the surgeons perfect it to where it kind of looks like a little snout on the outside of the body, or they turn it like this. Your loop stomas can look several different ways. They really can. Again, they're the ones that have these L-shaped rods or a crescent rod or maybe even a catheter up underneath it to help hold it up on the abdomen. So in your assessment, you want to make sure that you're documenting what type of stabilization device is being used. You know, is it some type of L-shaped rod like this? When is it scheduled to be removed? Is it the kind of rod that has the hinge that opens out? Many times these get sutured down, and if they're sutured down, you either have to pouch over it or carefully around it. If at all possible, try and get the skin barrier up underneath the rod, but that's not going to be possible if it's sutured down. Again, I mentioned that sometimes they use a catheter or a piece of rubber tubing. No matter what you're using, make sure that whenever you finish and get ready to put your skin barrier on, that the rod is centered appropriately with the stoma. You don't want it too far to the left or too far to the right, because when you put your pouch onto the skin barrier, it's going to put more pressure on it, and you don't want unnecessary tension that could cause the stoma to pull away from the skin. Sometimes when we pouch on top of these rods, whether it's this one or that rod or the butterfly kind of hinge rod I showed a second ago, sometimes it can cause deep tissue injury. So try not to put any more pressure on the skin than you have to. I showed you a double barrel stoma on the apron a second ago. This was when you have the separation of the GI tract and they bring both of the stomas out. You've got your proximal and your distal stomas. The distal stoma also goes by the term a mucus fistula because it's the one that can secrete the mucus. In your assessment, you want to make sure that you're doing full assessments on each of these stomas. So measure the stoma and get all the characteristics out of both of those stomas, your functioning stoma as well as the mucus fistula. Now, stents, here we go. These stents are these little fine bore catheters. These are put in to help prevent stenosis. They can come out on their own. If they do come out on their own, you know, don't just put it in that urostomy pouch and act like it didn't happen. Don't do that. Make sure that you're notifying the surgeon to let them know that the stents came out. Whenever you're working with the stents, sometimes it can be difficult for the stoma to behave. You know, it likes to keep just putting out the effluent and putting out the effluent. You might want to use something like a capture cartridge that you can put over the stents. It goes completely over the stoma, captures the output, whether it's feces or urine, and then you simply take the cap it up, and throw it away. So that's going to be a really handy way to isolate the stoma and keep the urine or the stool out of your way while you're doing your assessment. The stoma lumen. The stoma lumen, this is where the output is going to come out of the stoma. Again, we love it when it's right there in the center, but of course we don't always get that. Sometimes it's off to the side. Sometimes it's projecting the stool right back down on the skin, and it can be difficult to manage. Make sure that you're documenting the location of the stoma, and when you're doing that, we use the clock method. If we're saying where the lumen is on this stoma, we're going to say it's at 6 o'clock. Because if you look down there at the bottom, you'll see the opening is at the very bottom. That's called clock method. Just imagine there's a clock right over the stoma. And it's very easy to be able to explain this when you're talking to somebody on the phone. You can say, you know, my lumen opening is at 6 o'clock, and they know exactly what you're talking about. They know, okay, you're not dealing with a lumen that's right here in the center. Oh no, it's right down there at the bottom. And sometimes a different location can make it more problematic for whatever the reason. As we're talking about the color of the stomas, typically red or dark pink is the color that we want. Yeah, we're thinking good blood flow with that. But a healthy urostomy stoma might be pink in color. It's just the way it is. Now, I said a urostomy stoma might be pink in color. If it's a colostomy or an ileostomy and it's pink, I want to know why. Does the person have low hemoglobin? Are they anemic? What's going on with this person? When I see any of that bruising, you know, that purplish or darker red color, I've got to think, okay, what happened here? Was this during trauma from the surgery? Is it trauma from the rod that was placed in there? That can happen. Now, when we see that stoma that's blue, when we see the stoma, oh, let me show you this stoma right here. Yeah. When we see this stoma, this one is cause for alarm right here. Yeah, the stoma should not be black. It should not be dark. It should not look like a piece of coal. That makes us think it's missing its blood supply. But I do want you to know that whenever you're going to say that, okay, we've got ischemia going on here, we've got lack of blood flow, do a thorough assessment. Okay, let me pull this one back up again. With my black stoma, with this one right here, if this was a necrotic stoma, like the stoma on the right in the picture, when I put my gloved hand over the, just pretend I've got gloves on, and actually after I noticed my fingernails, I'm sorry I didn't do a manicure. So you don't know how bad I really wish I was wearing gloves. But if I put a gloved hand over the stoma, I'm not going to expect for it to feel warm if it's necrotic. As a matter of fact, when I take my gloved hand away, there may be some of the stoma that's stuck to it. That happens. But I need to do that because it may be that the stoma is discolored. Now, I wouldn't expect it to be black, but it might be more of a real deep maroon color or a bluish color, but it feels warm. It has that good texture to it. Well, it could have melanosis coli. What is melanosis coli? Melanosis coli is actually a benign condition where the patient has been using a lot of laxatives, and the laxatives discolored the GI tract. And hey, these stomas are made out of the GI tract. So that's why you would have melanosis coli. So again, where I'm going with this is when you see that darkened, that discolored stoma, that color that makes you pause and question if there's enough blood flow. In your assessment, make sure that you're documenting what's the texture. Does it have that normal stomal texture, or is it limp? You know, is it flabby? Is it mushy? Is it cold? Is it coming apart on your glove? Make sure that you're documenting that in your assessment. Typically, right after somebody has had ostomy surgery, their stoma is going to be edematous, taut, tight, stretched. This is normal, and it's going to be 6 to 8 weeks before it starts to shrink back down to size. As we talk about stomas, everybody's is different. Everybody's is different. What makes a difference is where in the GI tract was the, you know, is it being created? Is it small intestine? Is it large intestine? But some of them have textures, some of them have grooves, as you're seeing, and some of them are going to be really, really smooth. So they can just look a lot of different ways, I guess is where I'm going with that. As you're cleaning around the stoma, if this is in the acute care setting and you're using that white washcloth, well, we know that a little bit of blood goes a long way on a white washcloth. So the picture at the top That's what we're expecting to see. It's normal when you're cleaning around the stoma. It is normal to have a little bit of blood on your washcloth. These stomas are very vascular. I explain it to my patient the same way I explain, when you brush your teeth and you spit out the toothpaste and you have a little bit of blood in there. Well, your gums are the same way. It's the same way with the stoma, okay? But if you wipe around the stoma and you end up with a washcloth that has as much blood as the bottom image, something is wrong there. You're not supposed to have that much bleeding. Also, if you note that the blood is coming from the lumen, you want to make sure that you notify the surgeon on that one. With your assessment, look for any trauma that may have happened to the stoma. And we've got stoma trauma right here in this picture. And with this picture right here, the stoma trauma is actually from this person wearing an ostomy support belt, which is another name for a hernia support belt. This person was wearing a hernia support belt because she has a large hernia. And she was bending over and standing up and bending over and standing up while she was picking up pecans in her yard. And the bending and standing and bending and standing, her belt shifted. And the belt started traumatizing the stoma. You don't feel it. So her stoma had a lot of trauma. It took about 2 months for this to resolve. Something else that I want to point out on the stoma, in the center of it, do you note that dark color? That, my friends, is melanosis coli. This person took a lot of laxatives to have bowel movements prior to her ostomy surgery. So her stoma has melanosis coli. But it's not the dark color that many people are expecting to see. It's more of a wine or a maroon type color. So with trauma, it can be a laceration or it can be an area where something was rubbing, causing friction damage. And that's what you're looking at on this stoma. Sometimes when we're working with stomas, we find the stomas that have the little granulomas on them. Do you see the little granulomas on these stomas right here? Yes, those are those small little raised areas right down there on the bottom. They start out in this mucocutaneous junction right here where the skin and the stoma meet. And then these can actually encroach and grow right over the stoma itself. They become a pouching hazard when they're there. But you do want to note that on your assessment. We got to watch out for that necrotic stoma as well. Again, limp, loose, flabby. And in this picture right here, what this was a loop stoma, and you can see one end of it, it's still viable, but the other side of the stoma, it's necrotic, where it looks like stool in the very bottom of it in the center. That piece coming across is the actual necrotic stoma. When the stoma is going through the necrotic process, it can just be the outer layers of it, or it can be the entire stoma. With this one right here, this lady actually ended up going through hyperbaric treatments, which is not something that's normally done, but she did it self-pay. She went through hyperbaric treatments and she was able to salvage her stoma, actually, keep it from deteriorating anymore. It's the only time I've ever known of it being done. But thank goodness she was left with a budded stoma. What happens with some of these is this outer part is necrotic. It sloughs away and just leaves that smaller stoma behind. When somebody's going through this, there can be more odor with it, and because you've got fecal odor, but you've also got the odor of the body breaking down as well. Stoma varices. Stoma varices is something that comes from issues with the liver. And you have these dilated veins around the stoma, and it gives the peristomal area this purplish hue to it. You want to be suspicious of stomal varices when you have someone who has a lot of active bleeding around their stoma. Maybe they remove the skin barrier and they just bleed and bleed and bleed. Well, be suspicious about that. Now, why do stomas vary? My goodness gracious. One of the biggest reasons they're going to vary is because of the adipose tissue on our body. What are you talking about? Well, let me show you. I'm going to use this little adipose pad to simulate some fat on my body. Now, a second ago, when I created this colostomy, I simply pulled this right on through, through the front, simulating my skin. But now that I've got adipose tissue here, I am going to have to pull this stoma through the adipose tissue as well. Now, with this adipose, this might be what, 8, 10 pounds? You know good and well that's not realistic. Our patients can have increased adiposity of 30, 50, 100, maybe even 200 pounds. And the surgeon has to go through that adipose tissue, bring the stoma back through the adipose tissue, and then out onto the skin. This, folks, is when it gets difficult. And this is difficult for me to do working with cotton and fleece. I just don't know how the surgeons do it. I don't, because I tell you, it's difficult. I've done this time after time after time. And it's difficult. Why is it difficult? The adipose tissue makes it difficult. A few minutes ago, I made a nice protruding stoma. Now this stoma is flush, and I don't know if you can tell it, but I've got little creases around here too. All that is due to the adipose tissue that's on my body. The more adipose tissue, well, the more wrinkles I can have, the more contours I can have. Contours, what am I talking about there? I'm talking about muffin tops, belly rolls, spare tires, Dunlops, whatever you want to call it. The nice way to say it is abdominal contours. That's your folds, that's your rolls. And the more that you have, the more difficult pouching can be with some people. So these are several different kinds of stomas right here. For stoma shape, oh, we love that round stoma or that oval stoma. Let me have an oval stoma here. Here we go. Pretty oval stoma. Yeah, they can be regular or irregular. As I said, the adipose tissue on the body has a lot to do with that. Protrusion, I talked about that a second ago. A lot of adipose tissue on the body is going to affect the protrusion. It's going to be all that surgeon can do to be able to get this loop pulled up, much less make it protrude. Loop stomas are often done when somebody has increased adiposity, and the reason is the surgeons say it puts less tension on the blood supply. Another reason is, and this is a reason they like to do this if it's a temporary procedure, to take down a loop stoma, all they're going to have to do is sew it back together. Boy, I simplified that, but sew the bowel back together as opposed to, opening this back up and the end-to-end anastomosis. Sometimes our stomas are flush or retracted. If we have a flush or retracted stoma, you may not be able to see it if it's retracted, like the one at the top. Do your best with your assessment, shine a light down in there, and see whatever you can see. If you're able to take pictures, pictures go a long way in describing what you're looking at. A flush stoma, oh, let me pull my new little friend over here. I got me a little belt, a new little friend. This is a flush stoma. Let me turn it around sideways, and you can see that it's flush with the body. There we go. It's right here on a contour, so that's going to make it an unfavorable pouching plane for this person. But to be honest, sometimes the contour is not here until after the stoma is created. Just know that on your soft abdomens, the creation of the stoma may create the contour, but we also have a big fold right down here. Okay, so here's your flush stoma. a long protrusion. Okay, where's me a protruding stoma? Here's me a protruding stoma right here. This is a prolapse stoma. Now, when you have a prolapse stoma, it's not that the stoma, just falls off of the body. Actually, a prolapse stoma is turning inside out on itself, kind of like turning a sock inside out. So you've got a couple of layers of stoma in here. That's why they're so fat. And then if it's a fecal stoma, oh yeah, fill that bad boy up with stool and they can get really, really large. Depending on how long the protrusion is, it may put it at a high risk of injury. So you may need to find some type of guard to use to help to protect the stoma. Here's another couple of pictures of some that are prolapsed. As I said, that's telescoping away from the body. Stoma size, excuse me. Stoma size varies based on what part of the GI tract was used. Of course, an ileostomy stoma is going to be smaller than a colostomy stoma because of the diameter of the small intestine and the large intestine. And then the type of a stoma itself kind of, leans to be larger or smaller. A loop stoma is my loop stoma. It's typically going to be a larger stoma than the end stoma is going to be. And you've got that cross view right there on the bottom. You can see, and you can tell why. To measure our stomas, we like the measuring guides. I think I've got one here. I thought I had one in front of me, but I've got so much stuff laid out now. Yes, here we go. We use different measuring guides, kind of like this. Some of your measuring guides have oval openings in them because, I would say over half of the stomas that I see are not round stomas. But you can use these different measuring guides to measure the size of the stoma and to create the opening in the back of the skin barrier. So a couple of different uses there. You want to measure your stoma frequently during that first 6 to 8 weeks as it's shrinking down to size, using either the measuring guides or some other type of wound measuring device, measuring from mucosal edge to mucosal edge. Sometimes the stoma is very irregular shaped, and you may elect to do something like a template and draw the stoma out. You can even use the wrapping that many of the skin barriers come in, but draw the stoma out and make the person a tracing pattern to be able to cut out their skin barrier. Another thing you want to put in your assessment is the amount of output. So if it's a fecal stoma, you can say that the person emptied their pouch 3 to 4 times at 1/3 full. That's very easy. If it's liquid, well, you can pour it into one of the graduated containers and get the exact amount of output. If it's a colostomy, and this is the post-op time, it is anywhere from 24 to 72 hours before it becomes active. And if it's post-op ileostomy, not quite as long, usually 12 to 24 hours. Make sure that you're noting in your assessment the consistency of the output. If it's fecal, is it thick? Is it formed? Is it tarry? Is it bloody? And is there any odor, presence or absence of odor? If there is odor, what does it smell like? Is it foul? Is it pungent? Is it sweet? Those are good descriptive terms. Listen to those vowel sounds. That's letting us know that the GI tract is starting to function again. So make sure you're documenting this in your assessment. Some people feel like they have a large amount of gas that they're putting out. Our pouches typically have filters on them, or you can get them with filters on them. If they don't have a filter, the person can purchase a vent and put on there. You want to teach the person how to burp their pouch, separate a 2-piece system to allow the gas to escape. And if this is somebody who complains about having a lot of gas, have them keep a diary of how many times they're having to burp the gas out of the pouch. And I also ask them to record what they're eating, drinking, and the meds that they're taking that day as well. Now, if it's a urostomy stoma, it's functioning right away. You don't have that delay in the output, but the typical first output is going to be bloody output. For your urostomy stoma output, make sure that you're documenting what the urine looks like. Is it clear? Is it gritty? Do you see the mucus in there? Which you can, because this little conduit, little conduit for the ileal conduit, this is made of GI tract and it secretes mucus. So the mucus can be right in that urine. Note the color and note any odor as well. Now, there's something called the mucocutaneous junction. The mucocutaneous junction is where the rubber meets the road. It's where the side of the stoma is going to be sutured down to the skin. And sometimes we can have separation. You've got a little bit of separation right there at the top with my belt showing separation at the mucocutaneous junction. Whenever you've got sutures that you can note the number of, do that in your assessment as well. If you do have mucocutaneous separation, you want to document that using the clock method. So in this one right here, I could note it down there at 6 o'clock. The peristomal plane, as I mentioned before, that's the area about 4 by 4 around the stoma. Make sure that you're assessing that area really well. Note the skin there. Is it the color of the skin around the rest of the body? Or is there some type of color change? Is it red? Is it bruised? Is it open? Is it bleeding? Is it dusky? What's going on there? If it is open, is there partial thickness damage or is there full thickness damage? Do I have a lot of little lesions or ulcers around that area? Yeah, now I'm getting into these real peristomal complications. How about the skin turgor? How about the texture of the skin around it as well? I look at this picture and I think, I bet this is painful for this person. This would be contact dermatitis. We want to look for any kind of complications. Contact dermatitis, allergic reactions, allergy to the skin barrier or some of the products that they're using. Candidiasis, a yeast type fungal infection of the skin. We have to watch out for that too. And folliculitis. Now, do stomas feel pain? No, they don't. They don't. They lack the sensory nerve endings. So we don't have something transmitting that pain impulse. But the surrounding tissue, certainly, you can feel any disruption in that skin and definitely the irritation. Whenever your patient has pain, you can use the PQRST pain assessment to kind of help wrap your head around the pain. P, you're asking what provokes or preceded the pain. Q, you're asking what's the quality of this pain? Does it burn? Is it a twinge? Is it a stabbing pain? R is asking if it radiates. Does the pain stay in one location or does it move around? And S is your severity, on a scale from 1 to 10. T, we're talking time. How long did the pain last? You want to document that in your assessment too. Whenever you do document the patient is in pain, make sure you're noting their vital signs. Also, verbal responses or nonverbal responses. If this is a non-speaking person or a non-English person, you can use the FACES scale, also known as the Wong-Baker scale, and the person points to how they're feeling. Our manufacturers give us great tools. This comes to us from Coloplast. This is the ostomy skin tool, and it helps you grade and document that peristomal skin. We also have a tool from Convatec. This is the SAX instrument, and to be honest, we don't really use it over here. I wish we did. They're big on using it in the UK. But this one helps you identify, track, and monitor the progress, any healing too, in that peristomal area. There's also the peristomal assessment guide. You can find that on the WOCN website. Hollister also has a lot of great assessment tools on their websites, as well as downloads for your measuring guides. And sometimes you don't have a measuring guide and you're going to see an ostomy patient and you're thinking, what am I going to do? You don't want to get to the house and pretend that the feces is not on that measuring guide. You can always download you one. So download one from the Hollister website. They've got the circular and the oval. Note that a good thorough stoma assessment is going to be the foundation of ostomy care and management. If you're not certified in ostomy care, I recommend that you think about it. We've got 2 wonderful certifying bodies here in the United States, so think about getting certified. Now, I want to open this up for any questions. I know we got a few minutes, but I'm glad to hang out a minute or two over if we've got any questions. Holly, can you shoot me some questions?
Okay, this concludes the CE portion of this webinar course. We'd like to thank Joy Hooper for a wonderful presentation. We do have a few questions for you, Joy. So our first question is, why would they do the loop stoma or the double barrel stoma instead of a regular colostomy with one stoma?
Okay, the loop stoma, and years ago, when I first started doing this about 20 years ago, we only saw loop stomas if it was a temporary procedure. And that was because it was so easy for them to take it down, put the person back together. With a loop stoma, they're simply pulling that loop of intestine up, making that split, separating it. But when it comes time to take it down, all they've got to do is pull this back down within the body and close it up. Again, I'm simplifying it, but that is a lot easier than going from that end stoma. To be honest, end stomas are my favorite to work with. You've usually got more protrusion there. If it's a loop stoma, I need it to be a good functional loop stomas. Okay, and what I mean by that is if I can't manage it, how can I expect the patient to? So yeah, you have to talk to your surgeons. Many times the surgeon does the surgery, but they don't understand the problems the patient may be living with that type of loop stoma. So if you're working with a surgeon whose loop stomas are difficult for you to work with, make sure that you're talking to them and you're letting them understand that, hey, we need more protrusion here. We need more protrusion. Y'all, conversations can go a long, long way. They really can.
All right, great. Our next question is, do you have any suggestions for helping a patient who is refusing how to change the appliance, to learn how to change the appliance?
Social media might help them. They can relate to other people in the different social media groups that also have a problem. If this is somebody who has a fecal diversion, if they have a problem draining it, you could put them in a one-piece closed-ended pouch. So they simply take it off and throw it away. And they could do that with an ileostomy. They're going to have to purchase more of those closed-ended pouches because typically you get 60 a month, but that could be an option. And usually it is the fecal diversions that people have more problems, dealing with.
All right. Can you explain pouchitis? The location, the symptoms, the causes?
I sure can. Okay, pouchitis. Pouchitis happens with those continent diversions. Remember I talked about the continent diversion? Remember the Coke pouch? Well, the Coke pouch is one of the types that can develop pouchitis. What happens is you usually have an overgrowth of the bacteria that are normally living in that pouch anyway, but there's an overgrowth and you get an infection in the pouch. The person typically feels lethargic and just doesn't feel well. They have cramps, they can have abdominal pain, they can have an increased number of output, urgency and frequency, of their output as well. And that kind of pouchitis can happen with that Coke pouch, but it could also happen if the person has a J pouch too. And I didn't get into that, but if you know what I'm talking about, just know it can happen.
All right. Once a rod is removed, is there a risk of the stoma retracting to the point of the patient needing more surgery, or can they live with a very retracted stoma?
Oh, honey, they can live with it. We know we all have to pouch those retracted stomas. And sometimes it's not the rod being removed too early. It's just the patient's body. It's just the way that You know, the stoma is going to be edematous right after surgery, so that's usually as big as it's going to be. And so if it's retracted in the beginning, you know when that edema subsides, it's going to be even more retracted. Convexity is your friend. You know, you want to use the convex skin barriers. You want to be very careful in the post-operative period, but for the long term, it's going to be convexity. Did I answer that one right, Holly? I mean, did I answer that appropriately? I don't know if I covered everything that was asked in that question.
I think you did, but I did actually ask the person who asked it if that answered their question. So we'll see if they respond to that.
Okay, okay.
Our next question is, how do you manage peristomal skin irritation that is painful for the patient?
Oh, it's so difficult because they're already hurting and now you're going to get there and be working in this area. Whenever the skin is irritated, we've got to create a healing environment. And one of the things that we typically are going to do to create that healing environment is do something called a crusting procedure, where we're going to put powder on that raw skin. Now, it's just a veil of powder. We're not flouring that chicken to fry, okay? It's just a little bit of the powder. So if you pour a lot on there, brush off the excess. But then we're going to use some barrier spray, you know, skin barrier. That's like that. It's like a plastic that you're putting onto the skin. And the reason you're putting that layer of plastic onto the skin is it's a protective barrier, but your adhesive is going to stick better to that barrier. And the barrier on top of the powder creates a crust so the adhesive will stick to it. Now, what's happening up under that crust? Well, the raw skin is able to heal. It's able to epithelialize and close. Now, more glory happens when you go to remove that adhesive, because if you've done that crusting procedure, that adhesive is going to lift up that crust and not that new epithelializing tissue that you've grown up underneath there. So that's typically what I do whenever somebody's got that painful area.
All right.
That and diversion. Diversion goes a long way. Whenever somebody's in a lot of pain and you're working with them, and I do this if it's a wound or an ostomy, I get them talking about whatever they like to talk about. It's usually going to be pets or grandchildren. Get the person talking about something they like to talk about and then go in for it.
All right. Can you describe mucosal seating? Do you pouch over or around it?
Oh, wow. So with mucosal seeding, you're going to end up with, it might just be one or two of what looks like the little granulomas right there at the side. And it happens as they're stitching this down to the body and bringing some of that mucosal tissue, and it, you know, it's like it just takes off and starts growing right there on top of the skin. If I can pouch over it, I will. If I can't, I'm going to have to pouch around it. But I try and pouch over it. I do. I might use some type of moldable barrier ring to help me do that. But if at all possible, I try and pouch over it. And that was a good question. I had never been asked that question in 20 years. Good for you. Good for you.
All right. This one is a little bit of a case that they just want your opinion on, and if there are any ideas that you have. So it's a leaking end ileostomy peristomal hernia repair that was done on August 7th. The peristomal skin is burning and red, so an ulceration from a leaking appliance. The stoma has been established for a while and no issues until after surgery. They tried crusting and duoderm and the Econ ring. Do you have any other ideas?
Yeah, Cavalon Advance. The 3M. It may not be the Cavalon. It's the 3M Advance that's in the little wand. They make it in the smaller wand now. I have not personally done this, but I have seen just case study after case study after case study how it's really helped provide that healing environment by creating a area that will allow the adhesive to stay put on. And see, if you get that skin barrier on the skin, it's protecting that peristomal skin. So it's all about getting that skin barrier on, prevent leakage. But it's hard to do when you got raw skin. So that little wand, do any of you use that 3M little wand? You know, it comes in a smaller size now. That'd be what I would try.
All right, great. We do have time for just a couple more questions. So our next one is, what is normal pain in the stoma region?
What is normal pain?
Mhm.
I'm not going to say any pain is normal, but in the stomal region, many times when somebody is developing a hernia, they'll have pain in that area. And of course, if they've got raw skin, that can be pain too. That usually they know what that is because it feels like a burn on their body. And then you've got this skin barrier, this pouch that's just rubbing up against it, creating friction. But if it's a hernia that's happening within the body, that can be very painful for some people as well.
All right. Is the stoma large protrusion an emergency? Should we call the surgeon stat?
Okay, the stoma protrusion, are you talking about the prolapse?
They didn't specify, I would assume so.
Okay, a prolapse happens. And it may happen to the person once in their lifetime. It may happen once a week. It might happen once a day. It's very, very different. As long as the stoma is still functioning, we want to protect the stoma and it should be fine. Now, what they are usually going to do when you've got a prolapse stoma is they're going to cover it with sugar, table sugar, and create an osmotic gradient. And it just literally causes that stoma to just shrink right before your eyes. Not as fast as I just did, but within a couple of minutes, it's like salt on a slug, except it doesn't do the same thing as the salt did to the slug.
All right. We did have somebody who wanted to let you know that they use a 3M wand and it does work great for them.
Thank you. Thank you for saying that. Thank you for saying that.
All right, and we've got time for one more question. And I have a recurring problem with a yeast infection around and under the pouch seal. I've been prescribed cream and powder, but my seal will not stick, so I have to tape everything down. Do you have any suggestions?
She's been using powder and cream.
Yeah, she's been prescribed cream and powder for it.
The powder, is it number one, I would want an antifungal powder, and I would be crusting with an antifungal powder. If it's bad enough, they may even need systemic treatment, but I would first try crusting with an antifungal powder. So that means you're putting the antifungal powder on the raw area or the area where there's the yeast infection on the skin, and then using some type of non-alcohol formula barrier film. Do a couple of layers of that. Shorten your wear time to just maybe 2 days. That's how I would try to handle that at first. And
All
Holly,
right.
can I say something?
Yes.
At the end of my presentation, I meant to say thank you to Shield. Okay, I want to thank Shield for giving us this time and me the opportunity to. Y'all can tell I just love talking about ostomies, and I just want to thank Shield for supporting us and allowing us the time to do this.
Wonderful. Well, that's all the time that we have for questions today. We apologize if we did not have time to get to your questions. We will forward them all to Joy after the webinar and make sure that she knows what you had to ask.
I'll
We
get
would
back
like to
to
thank
you.
Joy Hooper one last time for a wonderful presentation. Thank you again for attending today's webinar, and keep healing.